I think that I will take most of my presentation from my experiences in Australia, but ask you to think about how this might apply to you. I wish to say that it's standard really for people to say there's no conflicts of interest, but every single one of us is conflicted. And I don't want to offend anybody in giving this talk, and I don't want to slander my colleagues at home, but I will. And I don't wish to lose the respect of the Sri Lanka Heart Association, for I think you do a fine job, and I'm very happy to be here. And we get the cream of your registrars as they prepare for specialist training. I'm actually a member of our local health board, which actually governs an area larger than England, and so I'm actually my own boss. I'm employed by the board and the executive, so I'm my own boss. So that's a bit of a conflict of interest. I've been bribed and been treated very well, so I'm not quite sure how that affects me. I've had numerous jaunts as probably most of us have had in the past. Unfortunately, that has been drawn to a close in Australia, and I still remember some of the things that I've had, and I don't know if I do feel guilty about them, but maybe I should. So I think that probably affects every single one of us in some way, manner or form. Conflicts of interest are never mentioned. My knowledge of your health system is very limited. I have been many years as an interventional cardiologist to Burma, and I realised just how little I knew about the system there when the doctors and the nurses in the cath lab got very agitated at 4 o'clock in the afternoon when it was time for them to actually pack up and go and work in the job that actually provided them with more than $30 a month, which they got for their routine job in the public hospital. I will try to look at it from the points of view of all the players in this, and including the doctors. So what is a conflict of interest? Well, when you actually go into Google, it will take some time for you to sort out the 265 hits that you get, and most of them are going to be fairly irrelevant. But one of the simpler definitions of conflict of interest involves a conflict, either actual or potential or perceived, between the person's public duty as a doctor and their private interest. And most of us actually share a bit of our life working in both public and private institutions. And so I certainly work within the public system, as I've been a full-time doctor in the public system, but we're allowed to have a right of private practice. We go out, and I must say that I earn a lot more out in the private practice from doing very little than in comparison with what I would do in the public system. In the public system, a lot of my time is spent on non-remunerative things, much as I'm sure our senior colleagues here have spent a lot of time on administration, on sorting out the way in which the cardiologists of the country interact with the government, and these are things which aren't productive. Whereas the slacker who goes off and works purely in the private hospital and puts in unnecessary stents into patients probably earns a considerable more. Now, I strike a note with some of my colleagues at home. There are people who actually work principally in private practice who are actually earning a lot more. I had one of my advanced trainees come to me many years ago and say he wanted to train heavily and return to his country of birth, which I won't mention, and to start up almost an orphanage type situation, be a missionary to bring up the poor and help the poor. So after his Porsche and his Maserati has arrived in Australia, he has actually changed his mind. And I think that this is something which happens to all of us. We don't stay. Now, I've just jotted down some of the things that actually can conflict when you're working in a private and in a public hospital. If you own or have a part ownership of a health facility, we frown upon that because it actually influences the way in which you treat your patients in that environment, and people should distance themselves from owning and working in a hospital which they have part ownership or have shares in. I think that in our country that's a complete no-no. And so I have some of my colleagues, some of my surgical colleagues will actually whip patients out from under our noses and take them off to the private hospital, not declaring the extra charges that they will incur when they go there. And this is a real conflict of interest. And I think that there are some private facilities within our area which do not have the facilities that we have. So if I bring a patient with unstable angina into a private facility where I know I can get a cath the next day, I have to balance that against the fact that if the patient has an infarct at 2 o'clock in the morning, they have to put that patient into an ambulance and shift it to our hospital, to the public hospital, where we have a 24/7 on-call stage. So I think that if you have a patient in a public facility, then to actually put them at higher risk into a private facility where there's not potentially the same facilities available is certainly a level of risk. The 30% lesion in the coronary artery can often turn into a 90% lesion in the minds of people. You've had a lot of talks today about how you actually regulate that sort of behaviour, but love is in the eye of the beholder. And if you actually fancy your money, then the 30% lesion is actually a 90% lesion, and the patient's life is going to be saved by you implanting a stent. And as long as you reinforce that, you are actually doing a great job. A very bad job. One of the problems of this is that you actually change the expectation of all the patients who are actually going to have coronary angiography. We change attitudes. Say, you're a very bad doctor because you just gave me a statin, an aspirin and clopidogrel, and doctor down there actually put a stent in, and they saved his life. Well, that's not true, and we know it's marginal, so that's not true, but that's what people say. And so the presentations we've heard before have actually backed that up. A lot of unnecessary investigations are performed in the private sector where a patient comes in with chest pain, they go straight to a cath without taking a real good history and without taking doing exercise test or any other interventions or a coronary CT. So I think that with patient care, we have all got conflicts. In trying to organise your cardiology system and our cardiology system, one of the problems is that we pay the people who actually do the leadership the least, because they have to spend most of their time actually doing the leadership and not so much time in organising their private practice. Most doctors in Australia get paid very well. I'm a pure staff specialist, well, I wouldn't say pure, but I'm a staff specialist, and I get a wage, and that's what I get. I do a little bit of private practice, which is marginal, and but I think that doctors in Australia actually do very well. All the staff doctors are still in the top 10% of the nation's earning capacity. There are very few poor doctors. I suspect that things are a little different here, and you are dependent upon actually generating some of your well-being from your private practice, and that is part of the evolution. But beware the situation that we are in, where we have doctors who are quite avaricious in the way in which they practice. And so I think that we need to have systems which actually allow people to be remunerated for the very important levels of attendance to patients in the public hospital, where basically the patients are sicker, older and poorer than the patients who can afford private medical cover. Administration is something we all think we don't actually have any capacity to do, and most of us don't, and that we don't certainly get trained for it. But you actually obviously have leaders amongst you who are doing a fantastic job. And that takes time, and it takes effort, and they have to make sacrifices for that. And that is really, in a way, not fair. Most of the doctors who have been speaking at this conference have been doctors who are employed at large public institutions in America, in your country, in Australia. These are the doctors who are going to turn up to a conference like this, enjoy it, and enjoy participating. Other people like to do other things with their time. So why is it a concern? Eventually the public will figure us out. We are in a situation where we need to have governance over the processes that we do, and our reputation is going to suffer. Certainly in my country, the people who have the best reputation and most trusted people in the universe are the ambulance drivers, not the doctors, and I think that there could be a reason for that. So there is a fixed bucket of money, there's a fixed cake to cut up, and the health and the national economy is dependent upon us spending our money carefully and appropriately. Another $1,000 taken out of the public purse to do an unnecessary cath, another couple of $1,000 to do an unnecessary stent, is money that can't be afforded. We need to avoid doing things that are unnecessary. But it's very hard to make change. There's been a lot of articles out about people doing aspirations of knees and looking into knees and washing them out and doing little snips and tucks. It is absolutely useless. There's no benefit whatsoever. And a lot of the stuff in cardiology we do is potentially the same, particularly unnecessary stenting. The environment, every time you tear open a package, there is another, of something made out of plastic, there is another cause in the environment. And I listened very carefully to your excellent speaker at the start of your program, and I think we've gone home with a message there. And we have a real responsibility in that regard. And patient care, obviously. So I'll just look at what the public want. The public want good access. They don't really want to pay anything for it, or at least they want to be able to afford it. But they also expect lots of money spent on other things as well. They trust the ambulance more than anybody, but they don't always trust their doctor. And so we got a certain number of second opinions necessary coming up, and often you have to be very polite in the way in which you disagree, otherwise you might end up paying a lot of money to a lawyer to defend you in court. The politicians want to be re-elected. They do actually have their best interests at heart, though, I'm sure, but they obviously look to their own electorate before they look to the global situation. So they'd much rather have a bridge across the river in their local electorate rather than a new hospital in the centre of the city, which will actually allow tertiary referral patterns to work very well. They do want good care. Then if they make promises at elections, they want to try to stick to them, and they want to stick to budget. The public health administrator, he wants to maintain his own employment. Sometimes they want to get out of the job as soon as they can, but they have to agree with the government to maintain their goals and to stick to budget and to keep errors to a minimum. They want to avoid doing things that are unnecessary, and they want to develop services. And most of our administrators we do actually, we're very suspicious of, but most of them are pretty high-minded, and I think that they do well. Now put that in comparison with the private hospital administrator in Australia anyway. They want to maintain their employment, but they get driven by the company that owns the hospital to actually keep things very tight. And they want to keep the institution profitable. They want to attract a particular type of doctor who gets cases which actually make the hospital money. They're not interested in the 90-year-old lady who's got a bit unsteady on her feet. That costs a lot of time and effort. So they want doctors who will bring a patient in, do an unnecessary, do a stent and get them out again the next day. So they are not interested with low acuity patients. They don't want to deal with patients who can't pay their bills. The health insurers, we have a system in Australia where about 40% of people pay into an insurance scheme which actually covers what you think are going to be most of your bills, but probably not all of them, and that allows you to go to a private hospital or have slightly better accommodation in the public hospital. And they want to look after their clients. They don't want prices to rise, and they're agad at the increase of things that they can't control. Because it's going to make sure that they've got to put up their insurance payments for their clients, and they want to try to alter behaviour of doctors so that they aren't doing things that are unnecessary or aren't going to help. What the doctor wants, it certainly varies, and each doctor changes over time, as I sort of explained before. I think we all change our attitudes over a period of time, and I suppose that I'm at the end of my career, and I think that my attitude is to ensure that we actually have a sustainable system which allows the best care to be given to people. So when I die, I can lie straight in my coffin and not worry about misbehaving, and I'd be forgiven for all the other things. So the doctor, he wants to make sure that his family are looked after, and that's fair enough, and that's very good. He wants status. We all enjoy status. He wants a Maserati. And he also wants to be head of the department, because the department head is obviously a fool and he thinks it all can be done better, but he actually failed administration 1.1. So there are many different types of employment in Australia. We have payment of Medicare, which we pay out of our taxes, which pays for most of your primary health care. We have our private health funds, which actually cover for private care in private hospitals. And we do have over-the-counter fees which people have to pay quite often to go and visit the doctor, and also the surgeon, depending on how unqualified they are, will charge you either a lesser amount or a greater amount, and the amount they charge is inversely proportional to their capacities to do a good job. So what to do? I don't know, really. I think, firstly, that we have to actually say there is an elephant in the room. We have to accept that there's an issue within all our health systems, and we have to actually cooperate with changing our health systems so that we actually provide the best bang for their buck that people can have. I think we have to accept that, and we need to do something. So I think that we need to understand who all the players are within our own environment, and certainly we need to call what the truth is. And I enjoyed Dr. McTaggart's talks. I'm sure I could see him dressed in blue charging over the hill, attacking the British with his sword in the battle of... He's a fiery chap, isn't he? Anyway, so that and I think that he puts challenges to us. And certainly one of the things that we do have within our organisation is a heart team. And it staggers along a bit, I must say. It doesn't seem to be working as well as he has his, but it is certainly one of the changes that we can make. I think we need to educate people into having an appreciation of what their responsibilities are within the system. And we need to have people who run the system who have the capacity to actually make judgments about the appropriateness of the care that is being given. And I think we need penalties, so that if we do misbehave, you have to be, in Australia, you have to be a really, really, really bad doctor, taking drugs and killing your patients, obviously, before you actually get struck off. You only get struck off for a short period of time, so that the penalties have to be real penalties. And it's a concern, I think, that if we don't recognise the conflicts that we do have within our lives and the way in which we act, our reputation will suffer, the health and national economy will suffer, and will eventually be pulled back. And I think that patient care does suffer. Thanks very much.